But it's nice to see familiar faces in the crowd today, and I look forward to talking to you a bit about collaboration and how important it is to our profession. I've got a number of disclosures to make. I had worked on advisory boards with the following companies. They have no impact on my talk today. There have been no financial incentives or any kind of support from commercial organizations either for this presentation today. So I'd like to talk about this very important topic today. And in discussing it, I'd like to talk a little bit about the context of our current healthcare system and where we stand today. So in terms of objectives today, I'd like to talk a little bit about how expanded scope and collaboration work hand in hand, how we can leverage our scopes of practice to better meet the needs of patients. And then finally, I'd like to talk a little bit about workplace realities and how we need to move forward on a number of key issues in that area. So just very quickly, in terms of the Canadian Pharmacists Association, our mission and our vision are deeply rooted in the concepts of excellence in pharmacy practice and how that impacts on patient care. You may be sort of interested in seeing the use of the word world-class in our vision, and the reason we mention it is that when we travel internationally to various conferences, we are constantly being told that Canada is really a leader in terms of pharmacy practice in what our pharmacists are capable of doing. And for us, this is actually quite a surprise, but in a lot of countries across the world, pharmacists are still very much involved in the distribution aspects that Bob has alluded to previously. And in Canada, we are moving beyond that, and we are able to impact Canadians in a much greater capacity. And this is a really good thing because we have a healthcare system that is in transition, and it's impossible to pick up the newspaper these days and not realize the stresses both in terms of unmet needs amongst Canadians as well as the cost restraints that currently exist in our system. So increasing demands on our healthcare system, changes in healthcare delivery models, and we're seeing an increased focus on areas such as primary care, a shift to more patient-focused care, this whole, and I'm going to be alluding to this a couple of times, this whole need to focus on cost-effective and financial sustainability in order to keep our healthcare system going, and efforts to optimize the scopes of practice, not only of pharmacists, but of other healthcare professionals as well, so that we can actually get Canadians the care that they need in our healthcare system. So these challenges in our healthcare system are echoed also within the pharmacy profession, and we've seen changes to pharmacy models. We see more pharmacists now involved in multidisciplinary teams than ever before. This has always taken place in institutional settings, but we're also seeing it in community settings and in other parts of Canada, and I understand here in BC as well, looking at multidisciplinary teams, family practices that are enhanced by other healthcare professionals, including pharmacists. We're seeing a lot of movement in this area. Expanded scope of practice, payment for medication management services. This is a big one as we continue to move forward in terms of new services. The reimbursement part is on top of all of our minds. Drug costs, access, and generic drug pricing is, of course, really important, and this is an issue that is not going away. In fact, we're probably going to see more movement on this in the fall of this year. Drug shortages, I don't need to elaborate here. We've all been impacted by it. Continues to be a problem that is not going away, and we need to find solutions to this. And also e-health and e-prescribing. I think pharmacists have very much skin in the game in terms of e-prescribing and e-health. We feel that our system could be significantly enhanced, and as an organization, we're very much in tune on this issue and pushing our policymakers to move quickly on this, more quickly than already. It's interesting to look at public payer priorities. We commissioned the Conference Board of Canada to look at this, and when I go through some of these, I can't help but noticing that private payers are also have some of these same priorities in terms of achieving better health system savings, leveraging this core skill set of pharmacists, improving health outcomes, serving the needs of high needs and high cost populations. This is a really important one. And then also exploring alternate approaches to leveraging the skill set of pharmacists. One of the key areas that I feel strongly about is that where Canadians can really, or where pharmacists can really own a part of the healthcare section is in terms of chronic disease management. I think it's alarming to note that 1 in Canadians has a chronic disease, and close to 15% of Canadians have 2 or more chronic diseases concurrently. You all know what these chronic diseases are. I would argue that chronic diseases are not all that well managed within our healthcare system, and it has a lot to do with accessibility. We know that pharmacists are one of the most accessible healthcare professionals that are out there, and so I believe it's fairly logical to assume that we as pharmacists need to own the chronic disease management space. And I feel that other health professionals are actually very much on board with this and believe that pharmacists can do more to actually own this space. The significance of chronic disease burden in Canada is quite overwhelming. 89% of deaths in Canada are attributable to chronic diseases. Between 1/4 and 1/3 of Canadians experience hypertension, and a lot of those are not effectively controlled. A lot of Canadians currently suffer from diabetes, and an alarming number of Canadians are currently in a state of pre-diabetes. So when it comes to chronic diseases and what pharmacists can add to this space, a lot of Canadians are on over 5 drugs or more for the treatment of chronic diseases. And what pharmacists, what we do and what our expertise is around dosing. It's around pharmacology, around pharmacokinetics, around drug interactions, drug monitoring, and of course now, pharmacogenomics. So pharmacists, we learn about this in terms of our education, and when we work collaboratively with physicians, closely with physicians, they quickly realize that this is a skill set that they don't have a lot of knowledge in, and that they can truly leverage the skills that we as pharmacists have to create optimal outcomes for patients and really optimize the drug regimens that Canadians are under. The number of prescriptions that people are taking are independently associated with an increased risk of emergency room use. And we know that our emergency rooms are overburdened. So this is a logical area for pharmacists to truly get engaged in. We know that people with chronic diseases, depending on the number of chronic diseases they have, the number of medications they take is escalating. And physicians definitely benefit from when we get involved in this and take an active role in the prescribing. What I think is a disruptor in pharmacy practice, and if you don't already know about this, and I'm sure many of you do, deprescribing is what I believe to be one of the biggest disruptors in pharmacy today. And it's an area that we have knowledge in, we have expertise in, but it's an area where we can grow that expertise. And that is, we do, as a system, and as prescribers, prescribers do an excellent job of adding medication when necessary, but they become very uncomfortable when it comes time to deprescribe, to take medications away from their regimen. So it's not uncommon for us to see seniors on 10, 15, 20 medications a day to treat their diseases. And when you start to delve into that, we realize there's a lot of duplicity. You end up scratching your head at the end of the day as to why some of the medications these patients are actually taking, why they still need it. Numerous studies have really shown that when we work collaboratively in teams and develop these collaborative working relationships with physicians and prescribers, it does indeed foster greater patient care. So we see improvements in adherence. We see greater support for patients so they can self-manage their chronic disease states in a better way. And this actually results in improvements in drug therapy management. The role of multidisciplinary teams, I mentioned this before, but it's absolutely critical that when you get the teams working together, that we can develop, lead, and implement evidence-based disease management programs, and we can work with a common voice and a common opinion on how we can best manage patients with chronic diseases. So we all know the players who need to be involved in these collaborative approaches, so this should come as no surprise to you. There is evidence to support a multidisciplinary approach, and this is just one of many studies, and I'm really happy. I work together with a number of pharmacy practice researchers across Canada, and this area is really starting to grow. More and more people are starting to use their practice sites as research hubs for pharmacy practice. But this was one study that was done on multidisciplinary education. It looked at patients who were receiving traditional care, so prescriber-driven care with supportive, quote-unquote, allied health professionals supporting physicians. But then the trial itself involved education sessions with a number of other practitioners, including nurse practitioners, dietary approaches to hypertension, physiotherapists inputting on the importance of physical activity, and drug therapy and adherence management by a pharmacist. And what the study found was that at 6 months, there were significant improvements in systolic blood pressure compared to the control group. So those who were receiving that enhanced management were actually shown to have better blood pressure management. Now, it's important to note that some of the other key markers for disease were not impacted. And so, the more study is necessary as to how we can really optimize this, but there are studies that are starting to demonstrate that pharmacist involvement can really make a big difference. One thing that's really important, I think, as pharmacists is that as we get involved in team approaches to health, that we're not duplicating the work that's already being done. So when we use a truly multidisciplinary approach, we don't find that there's duplication. Every member of that team is inputting their unique skills and not duplicating the work of others. It also ensures the continuity of patient care. All members of that team are speaking the same language. So if someone goes to a prescriber, they're hearing a message, and when they go to a physician, or when they go to a pharmacist, then they're hearing a similar message that's complementary to what the physician has already said. So we're not taking the place of physicians, but we're actually complementing what physicians are actually providing. I'm going to shift a little bit of direction here and talk a little bit about case finding. When I had my pharmacy, we used to always have clinic days, and we would have a number of people that were attracted to my pharmacy because we were having a hypertension clinic day, and we would randomly people would come by and say, yeah, I think I'd like to have my blood pressure taken. And it was kind of a blunt instrument to identifying cases of hypertension in our community. And I think the reason I'm bringing this up is I think we need to be very strategic in how we practice screening and prevention and chronic disease management, because what tends to happen when patients self-identify for these kinds of events is we get a lot of healthy people coming in and having their blood pressure taken, and it's like, oh, you're perfectly healthy, your blood pressure's normal, you have nothing to worry about. And yet we know the risk factors for hypertension. We know that people who are overweight, whose lifestyle may not support a normal blood pressure, males who are over 50, we know the risk factors. So in terms of what we could be doing and perhaps should be doing is actually doing case finding within our practices to identify those people who have not been diagnosed, who have somehow slipped through the cracks, and we ourselves, knowing our patients often better than anyone else, we can actually find those people who would benefit by an early intervention and the intervention that we can prescribe. So it's an area that there's growing research. There's some work out of the University of Alberta on this, and I think it's another area that we're going to see more and more pharmacist involvement in terms of screening and prevention. And I think it's an area too where we can go to physicians and say, look, we can complement the work that you're doing because we see so many of your patients on a regular basis. So one thing that CPhA has been doing for the last number of years is talking about expanded scope and how expanded scope has evolved across the country. In 2005, there was no expanded scope. We were very much a distribution-based profession, and things such as initiating prescriptions, drug therapy independently, prescribing for minor ailments, making therapeutic substitutions, changing drug dosages, renewing prescriptions, we weren't doing anything like this. And things have changed very rapidly in the last 11 years, and part of it was due to governments really acknowledging the value that pharmacists added to our healthcare system. Saskatchewan was one of the first provinces out of the gate who said that, look, we really need to acknowledge the fact that pharmacists are an underutilized resource, and we need to develop some collaborative approaches to making sure that they are fully participating members of the healthcare team. If we scroll forward to 2012, we had a major report in Ontario. I don't know how much news it generated in British Columbia, but it was basically a report that was looking at the services provided by the Ontario government. And an economist by the name of John Drummond was very vocal in saying that, pharmacists are an underutilized resource that could not only provide a cost-effective benefit to the system, but they were also very clinically effective in managing patient outcomes. So there were more and more of these reports that really demonstrated the value that pharmacists pharmacists could provide. And by the time we get to 2016, we notice that a number of other governments have really begun to support this and say that yes, pharmacists are an important part, and an expanded scope continues to grow within Canada, and I'm really pleased. But part of what we're trying to achieve as an organization is that expanded scope is harmonized across the country, so patients know what they're getting in one province is pretty well the same as what they're getting right across Canada. Nowhere has expanded scope been so evident than when communities experience emergencies. And what happened in Fort McMurray is a good example. What happened in the floods in 2011 in Alberta is another good example, where pharmacists were able to utilize their expanded scope fully to ensure continuity of care. So you had all these patients who were being displaced from their communities, their pharmacies were closed, their doctor's offices were closed, and they were fully utilizing their scope of practice to ensure that patients were continuing to receive their medications, they were continuing to receive their care, were continuing to prescribe, pharmacists were prescribing medication for minor ailments and ailments that were emerging. So, you know, these are, never is it more poignant than in examples like this, the impact that pharmacists can have. Coming back to some of the reports that have been done, 9,000 points of care was one of the first reports that itemized by dollar value the impact that pharmacists could actually could impact the system in terms of impacting the healthcare system financially and economically. We all know that some of the numbers with respect to adverse effects, they say now that the rule of thumb is about 1 in 9 hospital admissions to ER is due to the adverse effects of drugs. And this is an area that I think pharmacists can really step up in as we get more information in terms of e-health records and lab results, all those sorts of things in terms of protecting Canadians from the adverse effect of medications. And I believe pharmacogenomics, an area that pharmacists can own, is another way of ensuring that patients are protected against the unintended consequences of medication. I'm going to go a little bit quickly through the rest of my slides. There are have been studies that have been out there that have demonstrated the positive outcomes of what pharmacists are doing. It's interesting, I was contemplating removing this slide due to some of the results of studies that have emerged in British Columbia, the Lawson study that has demonstrated results of medication reviews. But this particular study is quite interesting because the patient outcomes with respect to medication reviews is one thing in terms of clinical outcomes, but what we realize is that if you sit down with a patient and you actually spend time with them and you do a robust medication review, the patient does indeed benefit from greater knowledge of their medication, learning things about how to take their medications, what to expect from their medications. They learn things that they didn't know before. We all assume through patient counseling that they're going to retain the messages that we provide, but sometimes often when we sit down in a medication review that's done well, we realize that there are a lot of holes and gaps in knowledge that patients simply don't have that we can really address in a forum like that. And so this particular study really demonstrated that. Also the deprescribing, which I alluded to earlier, is a significant positive outcome of the medication reviews that we can do. The role of pharmacists in adherence is, I believe, significant, and it's an area that payers are looking for us to really step up. Lack of medication adherence is really significant. Not only do patients not benefit from medication when they're not adherent to it, but the other thing too is it contributes to the medication cascade, because if it's determined that a patient is not benefiting from a medication, additional medications are added, and that's how we often end up with a patient on 10, 15, or 20 medications in one day. And I personally believe that a lack of adherence really does contribute to that significantly. So, I think in terms of adopting an approach to chronic disease management in our practice, there is a systematic approach that we can take, and you'll be hearing later from Dr. Sean Spina as he talks about the need for assessment, patient assessment, assessing patients' medication regimens, identifying drug therapy problems. All of these things that we can do forms a robust systematic process to addressing our patients' management of their chronic disease. I think I'm running a little bit out of time here, so I guess I'm going to speed up a little bit. Again, minor ailments is another area where pharmacists are contributing in various provinces and alleviating some of the pressure on emergency rooms and dealing with patients with self-limiting disorders that really do not require a physician or a visit to the emergency room. And there's good data to suggest that that is effective. There is good evidence that's emerging. I touched on that a little bit. There's a very effective website in Quebec where they are looking at pharmacy practice research and the impact of pharmacists in a number of disease states. And I would encourage you to take a look at that because there are hundreds of citations that are being amalgamated internationally that demonstrate the role that pharmacists have. So I'm going to leave this part of my segment with a discussion of, there are emerging issues within our profession, and it's an ideal opportunity for us to collaborate with physicians in order to ensure that we're all on the same page. And some of these, I think we're going to struggle a little bit as pharmacists, but we need to find the best way of moving forward with respect to meeting the needs of our patients. So these issues that I'm describing are things such as assisted dying. What is going to be our role? How are we going to work together with physicians on this? And they are seeking our involvement. So what are we going to do? Medical marijuana, what is the role of pharmacists in this? And again, how are we going to interact with physicians who are, to be quite honest with you, quite skeptical about the use of this medication in managing their patients? Mitigating the harms of opioid and prescription abuse. This is something that dominates our newspapers, especially in this part of the country. And how can we play a greater role, and how can we work with physicians to help mitigate this particular problem? A new drug that's coming on the market in the fall, mifegimisole, the abortion pill, and what is the role of pharmacists going to be in working with physicians and patients to ensure access to this medication? So how do we incorporate these into the roles that we already currently have? In the last few minutes, I would really like to talk a bit, and I apologize, I'm including a lot in my talk today, but the role of regulated technicians. I'm of that cohort that started practice when regulated technicians didn't exist. And I'm disappointed to some extent that we haven't moved more quickly in incorporating regulated technicians in our practice. And I think it speaks somewhat to our resistance to change, but I think it is incredibly important that we move forward with this quickly and fully integrate regulated technicians in our practice and registered technicians, because the benefits are indisputable. The registered technicians are gradually going right across the country, being regulated by their colleges, and BC and Ontario are leading in many respects. But there's still a lot of work to be done because the number of registrants is not keeping pace with the demands that are out there. We all know what registered technicians are capable of doing. The thing that's frustrating to me, I work in a practice in Ontario, and I guess it speaks a little bit to some of the challenges that are out there. I worked with a regulated technician a few weeks ago who was working at the time, and she said, "Well, I'm here, but I'm not working as a regulated technician." And I thought, that strikes me. What do you mean you're here, but you're not working as a regulated technician? And she said to me, "Well, they're not willing to pay me what I feel I deserve as a registered technician, so I'm just here as a technician. I'm just doing what is quote unquote an assistant job, even though I'm regulated." And it's like, to me, that was completely counterintuitive, and we need to find a way forward to changing that. I think the only way we can move forward as a profession is if we address some of those inconsistencies. Back in 2008, CPhA identified some of the pain points and some of the challenges with fully integrating regulated technicians. And I think a lot of those issues still exist today, and that is namely getting all our key stakeholders on board who can move this forward. The other part of it, also, is choreography. What does it look like in a pharmacy to optimize the use of pharmacy technicians? And I bring this graphic up here because the Ontario College of Pharmacists has come up with a video as to how to manage the choreography in a way to fully leverage the role that pharmacy technicians can provide. So there are change management issues. I'm not going to go into this in specific detail. The slides are available after, but I think we really need to find a better way of separating the dispensing role from the clinical role that pharmacists can provide, and we still are not there yet. And I notice it in the practice where I work. We're still struggling. We haven't clearly differentiated that role yet, and it's absolutely critical in order to leverage both of our professions. I'm going to leave on this slide on this topic, and that is that there's growing evidence out there that when we effectively utilize regulated technicians, that it can truly impact on patient care. And one of those areas is in continuity of care. We do not do a good job in managing care transitions, be it from acute care to long-term care or acute care into our community. And it's something I think we need to do better. And it's something that I believe regulated technicians are the ideal individual for doing that in terms of ensuring that best possible medication histories are established at those transitions of care. And in BC, you guys are very fortunate having PharmaNet. In other parts of the country, it's absolutely archaic and antediluvian, the systems that we have in place. But it really highlights the need for pharmacy technicians to be involved in this capacity. And when they do, we notice significant impacts, and these are identified on this slide. So in conclusion, it's absolutely important that Canadians are best served by a multidisciplinary healthcare team. We need to continue to expand scopes of practice to enhance the role of pharmacists and also of pharmacy technicians. The role of regulated technicians has not been fully leveraged in my mind, and it's a golden opportunity for us to move forward in terms of both of our professions, in terms of both regulated technicians and in terms of pharmacists. So I'd like to thank you for listening and would welcome any questions you might have. Thank you. So one of the questions that came up, which is actually very timely, is why don't we have specialty pharmacists like USA, psychiatric, cardiac, and this is referring to the Board of Pharmacy Specialties that exists. It's actually very timely because we have a national task force that is looking at this right now. We have done significant outreach and surveys to Canadian pharmacists to establish the need. I believe we're working in that direction. We have a number of possible options that we might look at. One of them is to tailor what is being done in the US, what the board is doing down there, tailor that to the Canadian market. The other is for us to de novo create a specialty framework within Canada, acknowledging the fact that this is an extremely costly and time-consuming effort to do that. But I can tell you right now, I can tell you that we are moving on this. It is part of our strategic plan as the CPhA to move forward on this. So I thank you for the question. Another question that I had is, will PharmaNet ever show exactly what pharmacy a prescription is filled at, or show lab results like Alberta has access to? Both would help everyday pharmacy life and patient safety. I unfortunately can't really answer that question in its completely, but I think a lot is being done on a national platform for e-health, and I think we're all going to benefit from that, including PharmaNet, to identify what the best practices are. This is clearly one of them, and I think we need to put our heads together as to how we can make that national also, because we know that Canadians are very, very mobile. The other question is, how can pharmacists advocate for themselves to expand their scope of practice? Should this be done provincial or national approach? I think both of those are worthwhile suggestions. I think the other thing that we really have to do that I didn't really mention was we need to be comfortable with going into prescribers' offices, scheduling time to meet with them and saying, you know, I'm a pharmacist, this is what I do, this is what expanded scope is all about. I'm not here to take your place, I'm not here to infringe on your turf, but what I'm here to tell you about is that we can work together and we can actually optimize patient outcomes by working better together. And I know that there are physicians who are perhaps not willing to hear that message, but there are also a lot of physicians out there who perhaps don't know a lot about what we do. And by us actually going to physicians and saying, look, I'm here for the same reason that you are. We're here to optimize patient care, and I'm here to offer up the services that I can provide to get there. I think you'll hear a lot of physicians who are supportive of that. Great. Thank you very much.